A very good morning to all of you, and welcome to the academic program. Today we have invited Dr. Sandamali Premaratne, who is the consultant cardiologist attached to District General Hospital, Negombo. She also holds the position of Joint Secretary, Sri Lanka College of Cardiology. So if you have any questions related to ECG, the topic for today is ABC of ECG. So send us your questions through the chat box, and we'll discuss those questions at the end of the lecture. So let's listen to Dr. Sandamali Premaratne.
Ladies and gentlemen, a very good morning to all of you. Today my task is to take you through the steps of interpreting ECG. I know it's not an ideal topic to discuss during pre-lunch time, but I will try my level best to keep this lecture simple and short as much as possible. So this will be the content of my lecture. I will be trying to introduce to the basics of ECG, and then I will take you through the basic steps of interpreting ECG, and I would like to highlight few important ECG abnormalities that you can find in your day-to-day practice, and also I would like to highlight few miscellaneous conditions which I think are important as well. So, what is an ECG? It's actually a representation of some of the electrical activity of the heart that is graphed against time on an ECG paper. So it all boils down to this, which is the important part of our heart, conduction system of the heart, where this electrical activity generates. This is actually MBBS stuff, but I will quickly go through this. We have, in the conduction system of our heart, we have a sinoatrial node or SA node, and then AV node. From the AV node, it starts his bundle of His, which divides into left and right bundle branches, and it divides into Purkinje system, and electrical activity travels from SA node to ventricular muscle through this conduction system. So, during the cardiac cycle, electrical pulses generates from the SA node, which is the pacemaker of our heart, and then repolarization of the atria occurs, and then these electrical impulses through the AV node goes into the His bundle and into the interventricular septum. Through that, via right and left bundle branches, electrical activity goes into the left ventricle, depolarizes the ventricles, and then systole of the left ventricle occurs, and afterwards repolarization of the heart cardiac muscle occurs. This is the basic conduction system and the electrical activity of the heart. So these electrical activities are detected by the electrodes which are placed over the skin, and there are several kinds of electrodes. They look at the heart in different planes and different angles. According to that, we get various patterns of ECGs. So, even though my topic is ABC of ECG interpretation, it should be PQRST of the ECG interpretation, because our waveforms in ECG are starting with PQRST. In an ECG, we have this isoelectrical line, and from this, when an electrode is placed on the skin, electrical activity, when it goes through the heart, electrode detects it. If the electrical activity comes towards the electrode, then it is depicted as a positive deflection. If electrical activity goes beyond, away from the electrode, then it is recorded as a negative deflection. So the first positive deflection is the P wave, and then comes the QRS complex. First negative deflection of the QRS complex is the Q wave, and the first positive deflection is the R wave. The negative deflection immediately after R wave is the S wave, and then you get the T wave, which is again a positive deflection. So P, Q, R, S, T waves of the ECG. This is our basic ECG waveform. So each of these waveform denotes the electrical activity of the heart. For example, P wave occurs due to the depolarization of the atria. You can see sinus node starts giving electrical activities, and then the electrical activity spreads through the atria, and it is detected as a P wave. And then through the AV node, it goes into the ventricles, and depolarization activity of the ventricle is denoted as the QRS complex. After that, ventricle and the cardiac muscle goes into repolarization stage, and that part is denoted in the ECG from ST segment to T wave. So each waveform shows the electrical activity of the heart, which is detected by the electrode. In a standard ECG, we have 12 leads, 6 limb leads and 6 chest leads. These leads, as I told you before, looks at the heart in different planes and different angles. And these leads are recorded by 10 electrodes, 4 limb electrodes and 6 chest electrodes. I hope all of you can remember these things. This is actually first year, second year physiology stuff. So these are our 4 limb leads: right arm, left leg and right leg. And these are our 6 chest leads starting from V1 to V6 that is attached across the, those are attached across the precordium. So this is a normal 12-lead ECG. You can see that these are the limb leads: L1, lead 1, lead 2, 3, AVR, AVL, AVF, and these are the chest leads starting from V1 to V6. You can appreciate that ECG wave patterns are different in each lead. That is again because I told you before, each lead looks at the heart in different angles. So for example, in V1 you get more negative deflections than positive deflections in the QRS, but compared to that, in V6 you get a more positive deflection and not much of negative deflections. That is because in V6 is more towards the lateral side of the precordium. So the heart is located like this here, and the whole electrical activity comes from atria to ventricle like this, and electrode detected as a positive deflection because electrical activity comes towards that. So the V6 get more positive deflection. So this is just to highlight, these are limb leads and these are chest leads. And these ECG leads, the limb leads, lead 1, 2, 3, AVR, AVL and AVF looks at the heart in a vertical plane or frontal plane, and the chest leads look at the heart from the horizontal plane. In the limb leads, we have 3 bipolar leads, lead 1, 2 and 3. These leads detect the electrical activity from, record electrical activity from one limb electrode, and to detect, record that you need a positive and negative poles. Here the other, one of the other 2 leads, electrode is taken as a negative lead. For example, lead 1 records electrical activity from the left arm electrode and takes right arm electrode as a negative pole, and it looks at the heart from the left or the lateral position. Likewise, lead 2 detect electrical activity from the electrode attached to the left lower limb, and it looks at the heart from the left inferior side of the heart. And lead 3 looks at the heart, again detect the electrical activity compared to the left upper limb lead and detected it from the left lower limb lead, and looks at the heart from the right inferior side. Actually, right leg lower limb electrode is an earth electrode. Same way, we have 3 other limb leads. These are called augmented limb leads, AVR, AVL and AVF. Here, one electrode is used to record the electrical activity compared to the sum of the electrical activity of the rest of the 2 electrodes. So in ABR, it looks at the heart from the right upper position, comparing the electrical activity of these 2 leads. Likewise, ABL look from the left upper side of the heart, and ABF looks from the inferior side of direction of the heart, or the electrical impulses are recorded from the inferior part of the heart. This is just to recapitulate what I said earlier. L1 looks from the left side, 2 and 3 from the inferior left and right side of the heart, ABL left upper, ABR right upper, and ABF inferiorly. These are important because later on we will have to localize our pathologies, and it all depends on these electrode placements. As I told you, we have standard 6 chest leads starting from the V1 to V6, and they are attached to standard positions like this. And we have some additional chest leads also. For example, we have right-sided chest leads. They are not done always, but in certain conditions we have to record leads on the right side of the heart. For example, V4R and V3R. And we have posterior leads also that again are recorded in special circumstances, starting from V7 to V9, and the electrodes are attached from the posterior side of the chest. So this is just to highlight that as I told you, from V1 to V6, electrodes are attached along the horizontal plane of the heart, and due to the electrical activity of the heart, the wave patterns are different from V1 to V6. Right. This is a summary of the leads and their area, that is that electrical activity detected from which area of the ventricle. See these 2, 3 and ABF leads detect the electrical activity of the inferior wall of the heart, and L1 ABL lateral. If you can appreciate here, L1 ABL lateral side of the heart, 2, 3 and ABF inferior, and then V1 and V2 looks at the septum, interventricular septum of the heart, and V3, V4 look at the anterior wall of the left ventricle, and V5 and V6 look at the lateral wall of the ventricle. So, if we were to interpret an ECG, better to start a pattern, otherwise we might miss things. This again is MBBS stuff. You may remember that we need to go each one of these steps to not to miss anything, starting from rate, rhythm of the ECG, axis, P wave, PR interval, QRS, ST segment, T wave, and QT interval. Let me show you what are these things. For example, I already told you P waves and QRS and T waves. PR segment is the interval starting from the beginning of the P wave to the beginning of Q wave. QT interval starts from the beginning of the QRS complex and until the end of T wave. So, how do we calculate the rate of the ECG? Simple. You know the speed of that ECG machine, the speed of the paper is 25 millimeters per second. So, you now calculate number of small squares between 1 hour to next hour, and you have to divide 1500 by that number. That will give you the heart rate. If this is this applies for the regular heart rhythm. If the rhythm is irregular, then you need to take 6 seconds of the ECG, that is about 30 large squares, and count the QRS number complexes there, and multiply that number by 10, then you get the heart rate per minute. Below 60 beats per minute is bradycardia, above 100 it is tachycardia. Again, basic stuff. So, how do we assess the rhythm of the heart? Normal ECG should be in a sinus rhythm, regular sinus rhythm. What do we mean by sinus rhythm? each P wave should be followed by a QRX complex like this: P wave, QRX, P wave, QRX. And between, these are called RR interval. Between each RR interval, the duration should be same. So that's why we call it regular rhythm, and it is a sinus rhythm because P wave is followed by QRS. P wave signifies the sinus node activity and atrial depolarization. So this is patient is in sinus rhythm. In compared to that, look at this ECG where the RR interval varies. This is because the ECG is, or the heart is irregular in rhythm, and you can see there are no P waves preceding each QRS. So the patient is not in sinus rhythm. Actually, this patient is in atrial fibrillation. Then next comes the next step. How do we calculate the axis? Cardiac axis represents the sum of depolarization vectors generated by individual cardiac myocytes. Normal axis should lie between this area, because if you imagine the heart like this, electrical activity comes from this direction to here, so the vector should lie here. So normal axis is supposed to be between -30 to +90. And we have deviations from these axes: left axis deviation, right axis deviation, and extreme axis deviation. So left axis deviation, if the electrical axis goes beyond -30, that is left axis, -30 to -90. If the axis goes beyond +90 to 180 degrees, then it is right axis deviation. If the axis falls somewhere here, then it is called extreme axis deviation. There are several methods to calculate the cardiac axis, but most efficient way is to look at the QRS complexes in lead 1 and lead ABF. Before going to that, I would like to appreciate this slide. In a QRX complex, when I say it is positive deflection, it is more R than S wave, more positive deflection. When I mean negative, there is more S compared to short R here. Equiphasic means both R and S are equivalent. So, in normal axis, lead 1 looks from here, lead ABF looks from here. If both are, usually both are positive, shows positive QRS deflections, so the axis lies here. Say if the patient has positive lead 1 deflection but negative ABF. Negative ABF means electrical activity goes away from the lead. So the axis goes to this angle. So it probably patient has left axis deviation. The same way, if the ABF positive but L1 is negative, that means electrical activity goes this way, then the axis lies here beyond 90 degrees. So patient has right axis deviation. Same way, if the both lead 1 and ABF shows negative deflections, then the axis lies between 90 and 180 degrees, then it shows extreme axis deviation. Why this axis calculation is important? Because there are conditions that are associated with left and right axis deviation and also extreme axis deviation. I would like to give few examples of left axis deviation. For example, left ventricular hypertrophy, left bundle branch block, left anterior fascicular block, and pace rhythm. Likewise, in right axis deviation can occur in RV, right ventricular hypertrophy, left posterior fascicular block, and in lung conditions like COPD or pulmonary embolism. Okay, so we looked into the rate, rhythm, axis. Our next step is to assess the P waves. It is the first positive deflection on the ECG, and it represents atrial depolarization. You need to look at the duration of the P wave and the morphology. Normal duration should be less than 3 small squares. There are few different P wave abnormalities that I would like to highlight. These are common things that you encounter. That's why I want to highlight them. First one is the P pulmonale, where P wave is tall. It should be more than 2.5 millimeters tall. This occurs due to right atrial enlargement. The other P wave abnormality is the P mitrale or bifid P wave. I hope you can appreciate the P wave is divided like this. This occurs due to the left atrial enlargement. And there are certain conditions, P wave get inverted. Usually P wave is upward in most of the leads, apart from one or two certain leads. If the P wave is inverted in leads where it should not be inverted, then that is most likely due to junctional or atrial arrhythmias. And sometimes P wave can change in morphology in each beat, and then we say the patient has multifocal atrial rhythm, because P wave originates from different places, different foci, therefore morphology changes. And then we go into the assessment of PR interval. It reflects the conduction through the AV node. You need to assess the interval or the duration of the PR interval. If it is prolonged, that means more than 5 small squares or 200 milliseconds, it signifies the delayed conduction through the AV node. It can be short also. Usually it should be about 3 small squares in an ECG, but if it is less than that, it is most of the time due to pre-excitation or WPW syndrome. Then assessment of QRS. You need to assess the duration of the QRS, whether it is narrow or broad, and need to assess the height or the voltage of the complexes. And there are certain patterns that you should be familiarized with, so you can diagnose them on the spot. Narrow complexes, QRS, like this one, where the duration should be less than 100 milliseconds. Usually these QRS complexes due to supraventricular, electrical conduction is from the supraventricular area. But if the QRS duration is more than 100 milliseconds, then it is called broad QRS. So most of the time, this originates from the ventricles or can come from the supraventricular area, but through aberrant conduction pathways, but not through the normal AV node. Voltage of the QRS. We need to assess whether the height of the QRS, whether it is too high or too low. If it is too high, we need to see whether the patient fulfills the criteria for left ventricular hypertrophy. Not all tall QRS are due to left ventricular hypertrophy. Sometimes it could be due to thin build patient, but still we need to calculate this one. We use certain criteria to calculate left ventricular hypertrophy. One is Sokolov-Lyon criteria, where you calculate depth of the S wave in V1 with R wave, either V5 or V6, height of the V5 or V6 R wave. If it comes to more than 35 millimeters, then patient has electrical criteria of left ventricular hypertrophy. And same way, we need to assess whether QRS complexes are too small also. For example, in limb leads, if the QRS is less than 5 millimeters, and in the precordial or chest leads, if it is less than 10 millimeters, then QRSs are small or low volume complexes, and there are certain conditions that are associated with. This is an example of the left ventricular hypertrophy. You can see QRS waves are tall, and if you calculate from S wave of V1 and R wave of V5 or V6, it definitely goes beyond 35 millimeters. And this is an example of the low voltage complexes or small QRS complexes. Especially in limb leads, it is less than 5 millimeters. This patient has hypothyroidism. That's why QRS complexes are small. And I said there are certain morphological patterns that you need to identify just by looking at this. One is left bundle branch block pattern. If you can appreciate that QRS complexes are wide, and then here in anterior V1 to V3 leads, it's more negative, wide, and lateral leads, V5, V6 and L1 ABL, it is positive, and it shows M pattern in L1 ABL and W pattern in V1. This is W and M pattern that is noted in left bundle branch block. And also you should appreciate that ST segment in the leads where the QRS is negative has gone up, but this is actually not definite ST elevation MI. This is due to left bundle branch block, and ST depressions occur in leads where the QRSs are positive. And same way, like left bundle branch block pattern, you need to identify the right bundle branch block pattern also. In V1, if you see RSR pattern like this, then it shows right bundle branch block pattern. And one more abnormality of the QRS complexes, morphological abnormality. This is also important. This is a patient with WPW syndrome. You can appreciate that patient has short PR and a broad QRS complex, and there is a slurring of wave pattern here in the QRS, and that is called delta wave that occurs due to accessory pathway. Right. Then we go into the ST segment. P wave, QRS, and then ST segment. It is easy. Either it is normal in isoelectric line, or it can be elevated or depressed. We all know ST elevation occur most of the time occur due to ST elevation myocardial infarction, but not always. There are other conditions that can cause ST elevation. I have listed few here. Same way, ST depression usually indicates myocardial ischemia or infarcts, but there are certain other conditions can give rise to ST depressions in ECG. I will quickly go through this one also. When we assess T waves, we need to assess again the height of the T wave and any morphological change like inversion of T wave. Tall T waves occur, the common conditions that can occur tall T waves are hyperkalemia and myocardial infarction, early stages of ST elevation MI. And T waves can be inverted in a lot of conditions. One important condition is myocardial ischemia or infarction. And then one important step of interpreting ECG is QT, assessment of QT interval. QT is the interval starting from the beginning of the QRS to the end of the T wave. Important point is find where the T wave ends. We usually use this intersection to find the maximum slope of the T wave, and we need to find the point where it intersects the isoelectrical line and calculate the QT interval from beginning of Q wave to this point. This is the correct QT interval, and there are calculation methods to get corrected QT interval. If it is more than 440 in men and 460 milliseconds in women, it is supposed to be prolonged. And for your purposes, if you feel it difficult to calculate this QT interval, a rule of thumb is that if the QT duration interval is normal, then it should be less than half of the preceding RR interval. There are various conditions that can cause prolonged QT, and I have listed few of them. Importantly, hypokalemia, hypomagnesemia, and hypocalcemia. Right. So these are the steps of interpreting ECG, basic steps, starting from rate, rhythm, axis, and then go through the wave patterns of the ECG, starting from P wave, PR interval, QRS, ST segment, T wave, and QT interval. Then you won't miss anything, and you can make a fairly good diagnosis depending on simply assessing these waveforms. Now I want to highlight few ECG abnormalities that are important, especially in our day-to-day practice. One condition is myocardial infarction or ischemia. You all know bulk of our ECGs are done to detect this condition, acute coronary syndrome. So acute coronary syndrome occur due to atherosclerotic disease. If the plaque ruptures and a thrombus forms, then you get acute coronary syndromes. If the thrombus completely occludes the artery, then ST elevation myocardial infarction occurs. If there is partial occlusion or the just erosion of the plaque, you get either non-ST elevation myocardial infarction or unstable angina. So ECGs can be are different in these two conditions, STEMI versus non-STEMI unstable angina. In ST elevation MI, when the artery is occluded fully, ischemia occurs initially in the subendocardial area. During that period, ECG shows tall tented T waves. That is the first sign of ECG that occurs during ST elevation MI. When the ischemia spreads to the whole thickness of the myocardium, then you get ST elevation. And then when the necrosis sets in, if we don't open up the artery, then you get deep symmetrical T inversions. That is the normal evolution of the ST segment and T waves during ST elevation MI. So the typical pattern of ST elevation due to transmural ischemia, there should be new elevation of ST segment at the level of the J point in at least 2 contiguous leads, and it should be 1 millimeter in all leads, at least 1 millimeter, except in V1, V2, where it should be 2 millimeters in men. If the man is younger than 40 years, it should be more than 2.5, and if it is a woman, it should be more than 1.5 millimeters. And importantly, ST elevation should be upconvex type of ST elevation. I will tell you why it is important later. So, can I take this down? With the time, this is how the ST segment behaves in ST elevation MI. These are important because sometimes you might miss these ECG signs and miss an important diagnosis. Initially, you get tall T waves, and within minutes, when the total ischemia sets in, you get ST elevation. After hours, ST elevation goes down. It's okay. And then starts to get the T inversions, and after days and weeks, ST segment is settled, but there are remaining T inversions showing myocardial necrosis. To interpret ECGs in ST elevation MI, it is important to know a little bit of coronary anatomy also. You know, we have 3 main coronary arteries. On the left side, left anterior descending, left circumflex rising from left main coronary artery, and on the right side, right coronary artery. So, left anterior descending artery supplies the anterior wall of the left ventricle. So, the ECG changes occurs in these leads, V1 to V6. And circumflex supplies most of the posterior wall, sometimes the inferior wall and the lateral wall. So, you get ECG changes here. And right coronary artery supplies the inferior wall of the left ventricle and the right ventricle. So, you get the ECG changes in inferior leads and sometimes V1 and V2. So, according to these ST segment detection in each leads, we name them differently. You see that if the ST elevation occurs from V1 to V2 to V5, we say it is anterior ST elevation MI. If it only involves V1 and 2, it is septal ST elevation MI. And if the ST elevation occurs from V3 to V6 and lateral leads, L1 AVL, it is called anterolateral STEMI. If it's starting from V1 and goes up to AVL, it is extensive anterior STEMI. And if it involves lead 2-3 AVF, it is inferior STEMI. And on top of that, if it involves in addition L1 AVL and V5-6, it is named as inferolateral STEMI. And there are posterior STEMI and RV infarction, which I will describe later. So that's why this table is important to detect the area of involvement. If you can go through this ECG, I think you can appreciate there are tall T waves in V2 to V5, and there are some Q waves in V1 and V2, negative deflections, and ST elevation L1 AVL and some ST elevation here V2 to V3, and importantly ST depression in L3 that occurs due to reciprocal changes. And this ECG is of a patient who has early stages of anterolateral STEMI. And in the same patient, this ECG is after 30 minutes. Now you can see worsening of ST elevation up to V1 to V6 and L1 AVL and ST depressions in L3, which is a reciprocal change. And now patient has full-blown extensive anterior ST elevation MI. Here you can see ECGs are bizarre, abnormal, large ST elevations involving L1, AVL and V1 to V6. And there are significant ST depressions in inferior leads 2-3 AVF. And this is called actually tombstone pattern of ST elevation MI, because it resembles the tombstone. So this again an important ECG sign that should be detected in anterior STEMI. All the ST elevations are due to ST elevation MI. As I told you before, there are other conditions that can give rise to ST elevations in ECG. And one important thing is this left ventricular aneurysm formation that occurs after STEMI. You can see in this ECG there are Q waves, that is, those are due to old MI, and there are persistent ST elevations that occur due to aneurysm formation. So, you know, in guidelines, there are for indications of reperfusion, we take ST elevation and also left bundle branch block, new onset left bundle branch block also included in that criteria in the guidelines. But how do we detect MI in a patient who already is known to have left bundle branch block? There are certain criteria to detect that those ST elevations. I told you before in LBB, if a QRS complex is negative, ST segment goes on towards the opposite side way, so the ST goes up in a normal LBB. But in MI situation, if a ST segment, QRS is negative, then the ST segment goes down, or if ST depression occurs. If the QRS is positive, then usually ST segment goes down, but in acute MI, ST elevation occurs in these leads. And also, if the ST segment is more than 5 mm, even in leads where QRS is negative, that is again taken as significant change and taken as anterior MI. I'm very sorry, this ECG is not very clear, but I think you can appreciate that where these leads, where these QRS are positive, you usually get ST depressions, but here you get ST elevation that is due to acute anterior STEMI. I told you inferior STEMI is detected when there are ST elevations in inferior leads, and there can be reciprocal ST depressions in lateral leads, like here. In 2-3 AVF you get ST elevation and ST depressions in L1 AVL. And RV infarction, that is right ventricular infarction, usually is, we can suspect RV infarction when a patient has inferior ST elevation, and also there can be mild ST elevation in V1 as well. We confirm the diagnosis by recording right-sided leads. I told you before, those are usually we do V4R, and this will show ST elevation. Posterior STEMI, again, we usually don't record posterior electrodes. So, we suspect from the normal ECG whether patient has posterior STEMI by detecting horizontal ST depressions in V1 to V3. Please remember, if there are ST depressions in V1 to V3, that is not due to non-STEMI. Most of the time, 99% of the time, it is due to posterior STEMI. How do we confirm? By repeating the ECG with doing posterior leads V7 and V8, V9. Here, example, ST depressions from V1 to V3. And if you turn this ECG backwards and upside down, you will actually detect ST elevation here. That is called mirror imaging of the ST depressions. And if you record the V7, V8, V9 posterior leads, you will detect ST elevations there. So this patient has isolated posterior STEMI. This is what I told you about mirror imaging. When you turn the ECG upside down and backwards, you actually detect this ST depression as ST elevation in V2. In non-ST elevation and unstable angina, there are patterns of ECG changes that occur. For example, these are the common ECG patterns in non-STEMI or myocardial ischemia: ST segment depression, T wave flattening or inversion. There are other ECG changes also. For example, T wave, tall T waves, and pseudonormalization of previously inverted T waves and U wave inversion. These are signs of myocardial ischemia. ST depressions, usually to be significant and to be taken as signs of myocardial ischemia, ST segment depression should be either downsloping or horizontal, and it should be more than 0.5 millimeter from the J point, more than 0.5 millimeter from here, and it should involve more than 2 contiguous leads. To take T wave inversion as significant, it again should be more than 1 millimeter in depth and should be present in more than 2 contiguous leads. And if it is dynamic, that means if it is present in and not present in all ECGs, then it significantly shows myocardial ischemia. This is an example of a ECG of a patient who had non-ST elevation MI. You can see that there are ST depressions in V4 to V6 and L1 ABL and some T inversions in lateral leads. And I want to highlight 3 ECG patterns that you will detect. These are very important because it significantly shows significant coronary artery disease. One is Whelan's syndrome. Other one is D winter T wave pattern. Other one is ST elevation in AVR. In Whelan's syndrome, you get T inversions in V2 to V3 leads. It can be biphasic or deeply inverted T waves, and it indicates, please remember, critical stenosis of left anterior descending artery, which is a very important artery in the subline anterior wall of the left ventricle. So detecting this ECG pattern is very important, so the patient can be sent for coronary artery interventions early. And in these ECGs, there should not be very much of ST elevations, and there shouldn't be Q waves, and R waves should be preserved in precordial leads. There are 2 types, type A and B. Here in type A, you get T inversions which are biphasic, up and down, and R waves are preserved and not much of ST elevation. This is type A Whelan's pattern. In type B, you get deep symmetrical T inversions, not like biphasic T inversions. D winter T wave, it is a tall, prominent, symmetrical T wave, again in precordial leads. This is preceded by upslope in ST depressions. Previously, I said ST depressions to be significant, it should be either downsloping or horizontal, but here ST depressions are upsloping and there are no ST elevations. But it is known that this ECG pattern is an anterior ST elevation MI equivalent. Even though patient does not have ST elevations, it signifies that patient may get anterior STEMI pretty soon. So it is important to recognize this ECG pattern. Tall T waves with upsloping ST depressions. This is an example of that kind of ECG with tall T waves and upsloping ST depressions. So important to recognize this ECG pattern. AVR is a lead that we don't talk about much, but this ECG change is important, which is the ST elevation in AVR lead. It is usually associated with widespread ST depressions in other leads. It shows either left main or left anterior descending artery stenosis, or it could be due to severe triple vessel disease, or it could be due to diffuse damage due to hypoxia or hypotension. But again, these coronary artery diseases are important, left main and LAD disease. So it is important to recognize this ST segment elevation in AVR, especially in a patient who comes with chest pain. Okay, so those are the important points that I wanted to highlight in ECGs in acute coronary syndrome, because those are the things that we should not miss. I will briefly highlight the basics about arrhythmia because I don't think I have much time now. So we know there are 2 different types of arrhythmias for us, bradyarrhythmia and tachyarrhythmia. There are different presentations of bradyarrhythmia. It could be due to sinus bradycardia, 6 sinus syndrome, or AV block. 6 sinus syndrome can present as simply as sinus bradycardia or sinoatrial exit block, or with sinus arrest like this, where you get sinus brady and QRS complexes, and there are after that no QRS complexes or P waves at all, that is due to sinus arrest, or they can present as tachybrady syndrome. This one is important, how to detect AV block. There are 3 degrees of atrioventricular block, first, second and third. In the first degree AV block, what happens is there is a delay at the level of AV node. You know that because of that, PR interval gets delayed. Here it should be less than 0.2 seconds, that is less than large square, but here it goes beyond that. This is due to the AV nodal delay. So the atrial electrical activity gets delayed to get conducted to the ventricular area. In second degree AV block, there are 3 different types, Mobitz type 1, 2, and then 2 to 1 or high grade AV block. What happens here is in first degree AV block, you get all the P waves are conducted to the left ventricle, but in the second degree, some of the P waves are not conducted to the left ventricles. For example, in Mobitz type 1, here P wave is not conducted to the left ventricle. That's why there is no QRS. But in Mobitz type 1, this is also called Wenke-Bach type of AV block, you get progressive delaying of the PR segment, and then suddenly P wave stops conducting and again starts progressive delaying of PR segment. In Mobitz type 2, there is no progressive delay of PR segment like that, but suddenly and intermittently, P waves stops getting conducted to the left ventricle. In 2 to 1 AV block, for 2 P waves, only one QRS is, one electrical activity is conducted to the ventricle. That's why you get for 2 P waves, only one QRS, 2 P waves, one QRS. This is called 2 to 1 AV block. And in high grade, like in 3 to 1 or 4 to 1 AV blocks, for 4 P waves, only one QRS is conducted. In third degree AV block, there is no conduction from atrial side to the left ventricular side. P waves or sinus node fires on its own, and because there is no electrical conduction, left ventricles take over and they fire then on their own rhythm and rate. So there is complete AV dissociation. P waves goes on their own rhythm, rate, and QRS goes on their own rate. This is complete heart block. Tachyarrhythmia, so that's all about, I'm going to tell you about bradyarrhythmia because it's a whole different topic. Tachyarrhythmia, if you were to assess tachyarrhythmias, best is to go again according to a method. First see whether it is narrow complex or broad complex tachyarrhythmia and see whether it is irregular or regular. Here, you see broad complex or narrow complex, whether it is regular narrow complex, irregular narrow complex, regular broad complex or irregular broad complexes. And there are differential diagnoses for each category. I will give you a few examples for them. This is a narrow complex regular tachycardia. You can see complexes are narrow, less than 3 squares, and it is regular. RR interval is regular and fast tachycardia. This is what we call SVT or AV nodal reentrant tachycardia. Here you can see again complexes are narrow, but it is irregular. RR interval varies. And again fast tachycardia. So it is a narrow complex irregular tachycardia. This patient has atrial fibrillation. Here you get complexes which are broad, but again regular. So broad complex regular tachycardia, and this patient has ventricular tachycardia. I have come to the last part of my presentation. I want to highlight these few conditions because these are some of the pitfalls we find when we try to interpret ECGs. One is this benign early prepolarization. Believe me, even us, the consultants, have detected these conditions as ST elevation MI. So it is important to note these changes. These ECGs shows ST elevation, but they are not true ST elevation. There are ST elevation at the J point, and they are smiley shaped or up concave type of ST elevation. Can you hear? It is said smiley type of ST elevation. And there is a J point here, which is called a fish hook pattern. This is actually not STEMI, ST elevation MI. This is called benign early repolarization. And then I want to show this ECG of a patient who had pericarditis. Again, you can appreciate ST elevations, but please see that ST elevations are occurring not confined to a certain area like inferior leads or anterior leads. It involves the whole anterior, lateral and inferior leads. And there are PR segment elevation in AVR and ST depression in AVR. And in limb leads, there are PR segment depression. These are the signs of pericarditis. Again, this is not ST elevation in MI, so it is important to recognize these changes so you won't misdiagnose patients. And one other condition like that is Brugada syndrome. You have 3 types of Brugada ECG pattern. All 3 shows ST elevation. Type 1 shows curved type of ST segment of more than 2 mm, followed by a negative T wave. Type 2 shows saddleback type of ST elevation, again more than 2 mm. Type 3, either curved type or saddleback ST elevation, but it is less than 2 mm. This is type 1. This is saddleback type of type 2. This is type 3. Again, this is not true STEMI. This is Brugada ECG pattern. And if you look at this ECG, very bizarre ECG, you get broad complexes, tall T waves, and these are sine waves, and these changes are due to hyperkalemia. Again, very, very important. If you miss, you will lose a patient. So what are the changes of hyperkalemia? Peak T waves, and initially widening and flattening P waves and PR prolongation that can develop into bradyarrhythmias, including high-grade atrioventricular block. And then you get widening of QRS and sine wave appearance. And finally, ventricular fibrillation, pulseless electrical activity or asystole, and patient can arrest. So these are my references. Thank you very much. I hope I managed to help you to interpret the ECGs with basic steps.
Thank you very much, Dr. Sandamali Premaratne, for that interesting and very informative lecture on ECG. And thank you, Dr. Sandamali Premaratne, for joining us today. And see you in next week.